basically, at the end of this 2-hour session, the students shall be able to first define the various sources of morbidity and mortality data used in public health studies and other epidemiologic investigations. We will be accomplishing pertinent public documents related to what we refer to as the civil registries of vital events. And lastly, we will determine important community health indices which are of public health significance. So this is actually related to the previous session last week when we talked about health indices with Dr. Duque Lee. So let's talk about sources of data. Whenever we engage with, before I start, I also have a disclaimer. Most of what I'll be discussing this afternoon will require a little bit of knowledge of higher medicine, meaning to say, it will involve a little bit of internal medicine, a little bit of pediatrics, a little bit of obstetrics and gynecology, as well as of legal medicine, which are basically third-year courses. The challenge is I have to simplify things to make it understandable at the level of freshman medical students. So the disclaimer is there will be a little bit of clinical background with some of the things I'll be discussing this afternoon, but I'm hoping I will be able to successfully simplify the concepts for you to understand the lecture for this afternoon. So let's talk about sources of data. When we're talking of epidemiology, when we're talking of research methods, we look into various measurements or sources of data. And we can dichotomize data into two types. You have your primary data and you have your secondary data. When we talk of primary data, these are obtained by the investigator or the researcher himself or herself. It is obtained firsthand, specifically to aid the researcher in answering the different objectives or purposes of why he or she is pursuing his or her study. Examples of your primary data would look into getting information that you derive from surveys, or when you do interviews, when you perform certain medical tests or examinations on your subjects. These are obtained firsthand and therefore they are considered primary data, and they aim to determine if a respondent will fulfill the definition of the case of a particular disease entity to which is very primal or primary rather to the research investigation. One of the things that you will be doing as freshman medical students is that we will be sending you to the community. I think one of the strengths of the UERM College of Medicine, in particular, the Department of Preventive and Community Medicine, and we take pride in saying that there is early community exposure to our medical students. If you go to other medical schools, you would learn that community exposure will begin during clerkship, which is your level 4 or 4th year medical school. But here in UERM, as early as first year, we bring the students to the community. These are photos that we took last year when we brought the current sophomores to the community in our adopted partner in San Juan City. And we literally ask our students to conduct home interviews. So they visited identified families in the community and they tried to identify leading causes of illnesses or morbidity cases in that particular locality. And this type of activity is, or community diagnosis as we call it, will entail obtaining primary data because these are information that you guys are actually getting yourselves. So this is an example of your primary data. On the other hand, when we talk of your secondary data, these are information that were obtained by other researchers for purposes not necessarily reflective of your current study, but they are considered previously existing information or data, which might just be helpful in your current study. Generally, this type of information has a large bearing with regard to the quality of facts obtained, since the investigator has no control whatsoever on how these data were obtained in the first place. Meaning to say, when these secondary data were obtained, the objectives behind that data collection may not necessarily be the same with your current research objective. And so there could be a slight differences with the way you look into your data. If you complete your postgraduate internship at the UERM Memorial Hospital, one of the clinical rotations that we deploy our postgraduate interns will be the site in Barangay Batis. And Barangay Batis is known to house the social hygiene clinic for the entire San Juan city. Meaning to say people living with HIV get their data or get their I'm sorry, people living with HIV and San Juan get the needed tests for their HIV related needs. For example, CD for count determination, viral load determination, or even the um, regular distribution, and this regular provision of your antiretroviral therapy. These are all provided by the social hygiene clinic. But our Philippine laws will dictate that whenever you get these services for free in the barangay, you would need to be part of the registry. So there is a registry, and sometimes the registry would collect information about the people living with HIV, in particular in Barangay Batis in San Juan City. So, for example, our sophomore students would do their research study that would involve people living with HIV because these are basically the hidden population. It's so difficult to really identify PLHIV. They're not your garden variety patients that you see in most outpatient clinics. And so you would need to have an accessible population where data are already existing. And this is where we need to tap the partner community and ask for existing data that can be useful for your particular research. So this is an example of your secondary data. In the same manner, when we're talking of data collection, at least from a public health perspective, there are those that we refer to as your notifiable diseases. There are certain medical conditions which, under Philippine laws, will mandate the healthcare provider or the doctors and the physicians and the nurses to report the presence or absence of certain medical conditions in a particular community. So again, when we're talking for notifiable diseases, these are medical conditions required by law to be notified or reported to health authorities upon the recommendation of the Department of Health. Now, these reports of occurrence of notifiable diseases can provide vital information regarding morbidity status of the community. This is a reflection of what was discussed last week by Dr. Duque Lee when she talked about the leading causes of morbidity. For example, when we're talking of the prevalence rate, for example, of hypertension, prevalence rate of diabetes mellitus, malignant neoplasms, versus, let's say, the incidence, let's say, of dengue, the incidence rate of your leptospirosis, or right now, if you are following the news, in Baguio just this week, there is the first report of your mpox. So these are examples of medical conditions by virtue of their high propensity for transmission. Health experts are required to report them, and we have to notify the general public. The reporting of these diseases is generally done on a weekly basis and is required for the purposes of surveillance and monitoring of important communicable diseases, just like what they mentioned just this week. I think it was the last yesterday or Sunday, I forget. But there was a news report that came out just this week about the mpox being in Baguio City already. So that's part of the surveillance and monitoring purposes of the Department of Health. Now, data on notifiable diseases are based on information submitted by health personnel from various units of the healthcare system. That is why we are still reliant on the reporting system at the grassroots level. Let's say, for example, from the rural health units, the city health offices, provincial health offices, or even the municipal health offices. Republic Act 3573 mandates the immediate accounting of any communicable disease of public health interest to the nearest health officer. Now, you might ask, what are these conditions that are considered notifiable? We have what we call your Philippine Integrated Disease Surveillance and Response, or your PIDS-R. And the PIDS-R has identified certain medical conditions which are considered epidemic prone. When we're talking of epidemic, it means I'm not sure if this was discussed during the introduction to descriptive epidemiology, but when we're talking, let's say, of disease burden, there is a difference between, let's say, epidemic versus endemic versus sporadic versus pandemic. There are operational definitions of these conditions. When you say epidemic prone, these are communicable diseases often that has a chance to be of, because of its easy transmission, there could be a sudden surge of cases in a particular locality or area that can be of public health burden. And so when we identify, let's say, for example, anthrax or meningococcemia or your paralytic shellfish poisoning or even malaria, leptospirosis, these are all considered epidemic prone diseases. Now, siguro, for academic reasons, sorry to say, but you just have to memorize what are regarded by the government as your epidemic prone diseases. On the other hand, we also have to look at it from from the concept of disease prevention and control. Remember your course last semester? We talked about disease prevention and control, and part of the public health concept is that there are conditions which are aimed for eradication and there are those which are aimed for elimination. When we're talking of these conditions, this will include your poliomyelitis, your measles, and your neonatal tetanus. If I am not mistaken, forgive me for the for lapse in my memory now, but if I remember correctly, in 2010, the Philippines was considered we were able to eliminate poliomyelitis already from the Philippines. However, post the controversy with the Dengvaksha, a lot of parents started to question the efficacy and effectiveness of vaccination, and we saw a significant decline in the fully immunized rate, fully immunized child rates of children, of Filipino children. And because people, children were no longer being vaccinated as before, suddenly come 2020, if I am not mistaken, or during and even during the COVID at the peak of the COVID-19 pandemic, we were able to see the recurrence of poliomyelitis in the Philippines. In fact, uh, not just the wild type of poliomyelitis, but even the other complicated forms. So, and we are saying that we were no longer able to eliminate, we were unable to maintain the zero or the eliminated status against your poliomyelitis. Now, you might need to remember again, there is a difference between eradication and elimination. This was discussed during disease prevention and control. But as a review of what you learned last semester, let me reiterate that when we're talking of elimination, there is zero incidence rate. Again, when we're talking of incidence in relation to the lecture last week, the incidence rate will refer to the number of new cases. This is to differentiate it from your prevalence rate, which is the number of new and old cases in a population at risk. So when we're talking of elimination, there is zero incidence for a particular medical condition. But for us to maintain and sustain that zero incidence rate, we need to have active interventions, active measures to sustain that zero incidence. For example, when we're talking of your poliomyelitis, you need to have your children, your babies, vaccinated. If we want to regain that elimination status against, let's say, your poliomyelitis, then we need to encourage mothers to have their newborn, their infants, their less than 1 year old babies to be vaccinated against your poliomyelitis. And we are now advocating for the giving of both your OPV and your IPV. On the other hand, when we're talking of eradication, we are still able to maintain the zero incidence rate, and there is no need for any intervention for us to maintain that zero incidence rate. A perfect and only example that I can think of will be the eradication of your variola virus. The variola virus is notorious for causing your smallpox. And today, do we vaccinate children against smallpox? No, we don't. Because of the successful vaccination campaign decades ago, and because of achieving a very good herd immunity response, people no longer were able to transmit the variola virus from one person to the next. Of course, there are conspiracy theories which allege that the US and Russia still keep the variola virus in their labs, in their military labs, supposedly for bioterrorism acts. No? And we don't know how, well, those are again just conspiracy theories, but listening to listening to the inaugural address of President Trump, parang kumisig worry tayo na mga nangyayari na sa bansa sa sa buong mundo, no? So anyway, just interesting facts. I just wanted to highlight again the difference between your elimination and your eradication. Now, there are also why do we also need to uh, be vigilant in terms of the notification for these for these communicable diseases. Now, we also have to we need to acknowledge that sometimes there could be a little bit of issue when it comes to the quality of diagnosis. And the quality of diagnosis of our health experts and health professionals can impact on the way we report notifiable diseases. Now, especially in your geographically isolated and disadvantaged areas or your GDAS, there are those which might not have all the necessary modern technology to come up with a definitive diagnosis for a medical condition. For example, in when we're talking of pulmonary tuberculosis, if you read the latest guidelines, the definitive diagnosis to establish a bacteriological confirmation for pulmonary tuberculosis, we would rely on the polymerase chain reaction or your MTB-RIF gene expert. But the thing is, let's say if you are in the far-flung areas in the island barangays, let's say in Palawan, where there are no medical facilities, more so diagnostic laboratories, they might not have the access to such bacteriologic confirmation of your pulmonary tuberculosis. And so healthcare professionals can have what we call your clinical diagnosis, meaning to say, based on the presence or absence of several signs and symptoms, then we allow the physicians to treat medical conditions based on their clinical eye or based on what they see primarily from history taking and physical examination, and not relying so much on your diagnostic workup. So sometimes this can impact on the way we notify certain communicable diseases because there could be areas where the actual diagnosis will rely solely on clinical grounds. In rural areas where volunteer health workers and midwives act as frontline health practitioners, symptom diagnosis is often practiced. Meaning to say, again, the constellation of a myriad of signs and symptoms would be the ones that will be reported and not the actual diagnosis. Another perfect example for this will be the WHO Integrated Management of Childhood Illnesses, or the IMCI. If you read the IMCI was initially um, designed for the volunteer community health workers in Africa, where there are really limited number of healthcare professionals. So if you look at the IMCI, the way they diagnose children, let's say with danger signs, they just say with pneumonia, without pneumonia. But they don't really come up with a definitive diagnosis, let's say, of acute laryngopharyngitis or tracheobronchitis, because they are not really trained to come up with medical diagnosis. So that's really more of the symptom diagnosis. And somehow all of these limitations can impact on the way we report occurrences of your communicable or your notifiable diseases. Now, post COVID-19 pandemic, we had Republic Act 11332, or the mandatory reporting of notifiable diseases and health events of Public Health Concern Act of 2020. Now, in this particular health legislation, they categorically defined several important terms. They talk about disease control, which refers to the reduction of disease incidence. Again, I hope you remember from the lecture of Dr. Dukili, incidence would refer to the number of new cases in a given population at risk, the prevalence, the number of new and old cases in a population at risk, morbidity, and the death rates to a locally acceptable level as a result of deliberate efforts and continued intervention measures to maintain the reduction. So right now we have come to the point that COVID-19 is more or less considered just your garden variety upper respiratory tract infection. But that was not the case during the early part of 2020, 2021, or 2022. I remember the first time we learned of COVID-19. I hold my private practice at the medical city. The first time I encountered a COVID-19 suspect, and the first time I was calling the the Research Institute for Tropical Medicines to report a probable case of COVID-19. I remember there was so much tension, there was so much social stigma about it. But over the years, because of the successful vaccination campaign, because of further understanding of this variant of your your coronavirus, we were able to become more prepared in how to handle COVID-19 infections and COVID-19 like infections. We also talk about disease response, which refers to the implementation of specific activities to control further spread of infection, outbreaks, or epidemics, and to prevent the recurrence of such communicable diseases. It includes verification, contact tracing, rapid risk assessment, case measures, treatment of patients, risk communication, conduct of prevention activities, including rehabilitation and reintegration. Remember the time when we were doing a lot of the contact tracing for your COVID-19 suspect? This is where we started to be more cautious. Excuse me. We started to be, excuse me. Sorry for that. We started to become more and more cautious of the way we handle our patients. And part of this disease response is the concept of why do we restrict movement, whether partial or complete, of certain people in society at the peak of the COVID-19. We identified the concepts of quarantine and isolation. Again, this is a review of what you learned last semester in disease prevention and control, because we want, as a response to an ongoing epidemic, as a response to an ongoing disease outbreak, we don't want further spread or further transmission of a communicable disease. And so, from a public health perspective, we implemented quarantine. If you will remember, the Philippines was sort of I'm not sure if we were praised or if we were ridiculed, but we were having the longest community quarantine ever. So if you will recall, from 2020 to 2023, there was a shift from your enhanced community quarantine to your modified community quarantine, so on and so forth. When we're talking of quarantine, we are restricting movement of those who are already who are well, but they have been exposed to someone who has a particular condition. So again, quarantine is used to separate and restrict the movement of well individuals who may have been exposed to a communicable disease to see if they will become ill. If you will remember, during the early 20 or the middle part of 2020, ang tagal pa ng quarantine, no? If you were exposed to, I remember when we were at the medical city, when we were first dealing with new cases of if a doctor attended to um to a COVID-19 confirmed patient, we had teams, no? Parang for example, one team would report for work for 1 week, dire-diretso, and then team B, that they would go on leave, then when they go home, they would have to stay in quarantine for 2 weeks. Then papalit naman ng team B, then another pagkatapos ng 1 week, team C may relievo. 2 weeks yung usual quarantine before, no? Na ginagawa natin. And those are actually very effective public health interventions to ensure that there will be no further transmission of the disease. That's why, di ba, healthcare workers, I remember bakit nauso ang Zoom? Because healthcare workers were forced to stay in hotels kasi they couldn't go home to their loved ones kasi their loved ones are not really exposed to the COVID-19. In contrast, when we're talking of isolation, what we are separating are those who are already sick. Now, if you go to the hospital when you become clinical clerks or postgraduate interns, we even divide the isolation into your clean and your dirty isolation. But for purposes of first year level, alam niyo lang na pag sinabing isolation, what we are trying to restrict the movement will be those of individuals who already have the disease or confirmed to have a medical condition. Then we have your disease surveillance. This refers to the ongoing systematic collection, analysis, interpretation, dissemination of outcome specific data for use in the planning, implementation, and evaluation of public health practice in terms of epidemics, emergencies, and disasters. I remember pre-pandemic na not all doctors really appreciated preventive medicine or epidemiology because they thought it was such a, very geeky type of topic. We talk about research, we talk about public health, and not all clinicians are really into, population-based interventions. But post-pandemic, suddenly there is a change in the language of all healthcare providers, even the nurses, the medtechs. You saw that they were very now keen on why it's important to do this surveillance, why it's imperative that we look into data, and how do we interpret the data in terms of coming up with program plans. So a disease surveillance system will include the functional capacity for data analysis as well as the timely dissemination of these information to persons who can undertake effective prevention and control activities. Now, because of the COVID-19 pandemic, we started to once again give emphasis to what we refer to as your emerging and re-emerging infectious diseases. And we're talking of these emerging and re-emerging infections. These are those that are not your garden variety conditions, or they have been present, but they don't normally cause so much disease, let's say, in human populations. Um, they have occurred through human history, but for some reason, uh, they are considered distant disease due to an infectious agent, or those that have been previously known to be um, causative organisms that have more or less mutated to become a new strain. And so we tend to be more vigilant now for these emerging and re-emerging infections. I remember uh before, when we were in medical school, we used to talk about leprosy as something that are considered social pariahs, even in the Bible. When we're talking of the lepers, we talk of Hansen's disease or leprosy as something that was of, they're considered a social disgrace because they can be easily transmitted. But over the years, we've seen so much improvement with the way we handle Hansen's disease or your leprosy with the advent of availability of your dapsone and other anti-mycobacterial species. We were able to slowly control leprosy. And in fact, when I was doing my residency from 2004 to 2006, I actually didn't see much of your leprosy patients. Siguro during my dermatology rotation, I would see, once in a while, but not as rampant as during the early 1990s, perhaps. But now, fast forward 2020s, we are seeing recurrence of your Hansen's disease, no? So, nagkakaroon ng re-emerging. Why? So, this is something that is a bit perplexing. And for epidemiologists, tropical medicine, infectious disease specialists, it's interesting to know why we need to be very careful in identifying these conditions. Or if you've heard of what we call your prions disease, your prions are basically viral proteins that are capable of causing spongiform encephalopathy in the brain or basic in the central nervous system. Basically, if you've heard of the mad cow disease, this is an example of your bovine spongiform encephalopathy. Now we're seeing recurrence or re-emerging of your prions disease these days. So again, why? Why the sudden occurrence? Kasi before, when we're talking of the prions disease, it was common because of the act of cannibalism during the early 1960s, 70s in a certain tribe in Papua New Guinea, wherein tribesmen would eat, children were forced to feed on the brain matter of dead chieftain. And so it started to, but the WHO controlled that, stopped that practice of cannibalism. And so there was a certain control for your spongiform encephalopathies. But now we are seeing resurgence of your prion diseases, and it's part of what we are trying to monitor in terms of emerging and re-emerging infectious diseases. Post COVID-19, there is a shift with the way we notify these communicable diseases. Again, for academic purposes, I think you will just have to memorize what are considered category 1 notifiable diseases in the Philippines, meaning to say, if you even suspect to have any of these, healthcare professionals are mandated to immediately notify health experts. Look at this, even HFMD, hand, foot, mouth disease, which is transmitted by the Coxsackie virus, measles, and of course your SARS and even your rabies. Then you have your category 2, which are reported on a weekly basis. So again, I know it's information deluge for some of you, but literally you just have to memorize what are those that would fall under category 1 and what will those fall under category 2. Now, we also have what we refer to as your civil registries of vital events. Yung mga, why do we have to report birth? Why do we have to report marriage? Why do we have to report death to the various local civil registry offices? Because again, these are things that are part of the documentation of vital events in the life of a person. When we're talking of civil registry, civil registration is the continuous, permanent, compulsory recording of the occurrence and characteristics of vital events as defined and provided through decree or regulation in accordance with the legal requirements of each country. It is done primarily for their value as important records or legal documentation, and secondarily for their usefulness as sources of health statistics. So may importante ito, especially when we're talking of the certificate of death, no? Very vital yung certificate of death. And this is the challenge for us because the only time you will, I think, encounter proper accomplishing, proper filling up of the certificate of death and the certificate of life, that will be in first year, which is now today. And then fast forward to clinical clerkship, you will be tasked to come up with your with the certificate of live birth and the certificate of death. I remember when we were clinical clerks and postgraduate interns, that was our task to come up with a diagnosis. But of course, our resident doctors and the training consultants would check on your work. But we were the ones who were accomplishing it. And I remember before, no, hindi pa uso ang computer, we would even have to type. If you're familiar with the, old school typewriter, it was such a laborious task of, typing. But we were also required to accomplish a certificate of death. So it also entails that you must be knowledgeable on how to accomplish a certificate of death. But accomplishing the certificate of death will entail background knowledge on pathology, on internal medicine, pediatrics, obstetrics, gynecology, or even surgical conditions. So let's talk about the certificate of death, which is a permanent legal record which contains an individual's death information. It provides data on the circumstances surrounding the death, and it has multiple uses. So whether we're talking settlement of claims, inheritance, insurance benefits, as well as proof of death. On top of it, you cannot, in a strictest sense, bury anyone without a certificate of death. Although, if you read our manual, there are certain provisions under the law which are considered exceptions as to when burial can be facilitated in the absence of a certificate of live birth. You might not know it, no? Pero ngayon, kung minsan, uso na rin yung mga tungkol sa mga settlements, mga insurance claims. In the US, for those of you who plan to work in the US, this is really becoming a headache for some doctors because the way the health insurance companies would provide the benefit, the claims, no? Ito medyo, it entails a lot of, social rapport. And so it's important that really are familiar on how to properly accomplish the certificate of death. Now, the cause of death, as certified by a licensed doctor, is the record of an individual's death information. Being responsible for the clinical diagnosis of the cause of death, the doctor plays a pivotal role in the cause of death certification. The clinical diagnosis by a doctor is the basis for the certifying the cause of death, and when entered into a certificate of death, it will establish the cause of death for that particular person. Now, here is the challenging part. You need to be familiar with the International Classification of Diseases, or what we call your ICD-11, meaning to say you can only stipulate in the death certificate a diagnosis that is seen under or gets recorded under ICD-11. If the ICD-11 does not bear that diagnosis, then you cannot stipulate that as a cause of death in the death certificate. So each diagnosis would have a corresponding ICD code. And when you come up with your ICD, when you come up with your death certificate, if you are to identify or give your causes of death, you need to conform with the ICD-11. And whatever you input in the ICD, whatever you input in the death certificate using the coding system of ICD-11, this is also reflected under the PSA, or the Philippine Statistics Authority data of the DOH. This is the latest data that I got from the PSA as of November 2024. This is from January to April 2024 only. So for some reason, maybe because we're only in the first quarter of first month of 2025, that's why there is still no available information towards the latter part of 2024, but this is the latest data. So it's a consolidated number of leading causes of death or leading causes of mortality among Filipinos. And notice that ischemic heart diseases, followed by malignant neoplasms, your stroke, your cerebrovascular diseases, then pneumonia, and your diabetes are the top five killers among Filipinos. Why is it important that we are familiar with the leading causes of death? No? Because we also have to come up with health policies as to why we need to give so much premium on the prevention and control of these leading causes. If you go to Ateneo School of Medicine and Public Health and you listen to one of their MD MBA classes, they really give so much attention to the statistics because they are training their medical students for health policy or program planning. And when you talk of, let's say, population health, it is imperative that you know you are able to competently understand data from a public health perspective. Let's say, looking at this chart. So, for example, if I were, we do know that health has been devolved to the local government unit. So, if let's say I am a governor, if I am a city mayor, and I want to prioritize procurement, let's say, of medicines for my constituents, I would most probably allocate more funds for the purchase of medicines against ischemic heart diseases, malignant neoplasms, brain attack or cerebrovascular diseases, pneumonia or diabetes and hypertension, rather than focusing, let's say, against dengue or leptospirosis, because these are not the priority concerns of your country based on the leading causes of morbidity. So this is the importance of why we look into health data. And all this statistical information of the PSA are all consolidation of what have been reported from the various certificates of death that were passed on to the local civil registry offices. Now, the road to good quality data starts with the clinical diagnosis of the doctor as to the cause of death. As for the cause of death, you have your immediate, antecedent, and your underlying causes. So, we will go into this in a short while, but what is important is that you need to understand why we need to come up with competent diagnosis. So, for example, later on I will look into this. There are times where doctors, especially if you only handled the patient for a few days or a few hours, you might not be able to come up with a very extensive medical impression factoring all existing comorbidities. And so it takes on a little bit of training. That is why most of the death certificates are accomplished in the hospital, where the assumption is the hospitalists have undergone formal training in residency and or fellowship for them to come up with the causes of death. But technically, even general practitioners should be competent to accomplish the certificate of death. Now, sometimes there is a dilemma when, let's say, hello, can you hear me? Is my audio clear?
Yes,
Yes,
po,
sir.
sir.
Okay. So the dilemma is sometimes you need to come up with a death certificate, but you did not witness the death of a patient. And that is very true if you go to the far-flung areas of the Philippine archipelago. The sad reality is, according to the latest data of certain non-government organizations, they allege that 9 out of 10 poorest of the poor Filipinos have never seen a healthcare provider in their entire lives. And so they die without ever seeing a doctor. But you cannot bury them if they don't have a death certificate. So what will you do? So we need to perform what we refer to as a verbal autopsy. For many deaths occurring in the Philippines that are not attended by a licensed doctor, the best way of ascertaining the cause of death is through verbal autopsy. And this is accomplished by interviewing next of kin or interviewing family members who may be knowledgeable as to the probable cause of death. Now, this task is now passed on to the local health officer, since it is the local health officer, the CHO or the MHO, who will accomplish and sign the death certificate of Filipinos who died without ever seeing a doctor in their entire lives. So, how do we perform the verbal autopsy? The World Health Organization recommended this as a partial solution to the problem of lack of cause of death data whenever there is no medical attendance. Verbal autopsy is one way of determining the cause of death based on an interview with next of kin or other caregivers. And this method is undertaken using a standard questionnaire that would look into signs and symptoms, medical histories, or any other psychosocial circumstances preceding the death of an individual. Verbal autopsy instruments are based on the following assumption. Whenever a person dies because of epidemiology, we are familiar as to the cause of death based on clustering of similarity of medical conditions. The signs and symptoms experienced by the disease can be recognized, remembered, and reported by family members and relatives, and it is possible to correctly diagnose death based on the reported information and to categorize them into groups of causes of death that are useful for public health purposes. For example, I am a primary care diabetologist, and I cater to a lot of diabetic individuals in my private practice. If you are familiar with the natural history of diabetes, if you let diabetes to take its natural course, diabetics will only die of there are only two ways that diabetics will die. They die of either a brain attack or a cerebrovascular accident, or they die of heart attack or your myocardial infarction. Unless, of course, masagasaan sila or binaril sila, no? Or yung mga traumatic causes of death. But otherwise, if you just let the natural history of death, you would know that they will die of those. How will you know kung may diabetes? You have the classical symptoms of polyuria, polyphagia, polydipsia, with or without weight loss. Dagdag mo pa yung mga symptoms na merong sugat na hindi gumagaling, non-healing wounds. You would notice ants in the urine. Those are classical symptoms of diabetes. So even if I am not a doctor, I simply ask the family member, does this patient wake up at night just to go to the bathroom and pee? If the family will say yes, he goes out of bed 3, 4, 5 times every night, then you know that is nocturia, which is an equivalent of polyuria. And then you ask, surrounding the time of death, did the patient complain of severe chest heaviness? Or, sorry for that. Or did the patient experience severe headache? Was there slurring of speech? Were there motor and sensory deficits? Those are red flags or classical symptoms that would lead to either your stroke or your heart attack. So even if you did not see how the patient died, you would already have an idea as how to the patient died, and you can come up with a competent medical diagnosis based on just listening to the way the family members or the caregivers describe the events leading to the demise of the patient. The main objective of a verbal autopsy is to describe the cause of death at the community level or population level, where civil registration and death certification systems are unfortunately weak, and where most people die at home without having had contact with the health system. So this is what I was saying earlier on. Now there are two stages. Oh, sorry, did I miss out on something? Okay. So there are two stages involved in physician-coded verbal autopsy. First, the interviewer will visit the household where the death has occurred to interview the family members, and then you record all the responses using a standardized manner. Then the pattern of responses will be reviewed by the licensed doctor that will ascertain or more or less have a good educated determination of the probable cause of death based on the signs and symptoms reported by the respondents. Now, who can certify the death of a person? First, if the person dies in a medical facility, more so yung mga long-standing patients, patient was in the ICU for 3 weeks, then definitely the attendings or the attending physician can accomplish the certificate of death. Now, in the event that let's say a patient dies at home or a patient was found dead, let's say yung mga salvage victims, well, let me change my second scenario. Let's say patients who died at home. It is the it is the city health officer or the municipal health officer who should certify the death of the person. Now, in the event that there is no medical attendant at death and the local health officer is not available, then the mayor or the municipal secretary can issue the certificate of death, but only for purposes of burial. Kasi syempre, how will the mayor and the municipal secretary, if they have no background, if they don't have medical background, how can they come up even with a medical diagnosis? So, for purposes of burial, it's the mayor and the municipal secretary. Now, yung kanina ko, kaya ko binawi yung kanina ko, syempre, if there is some question as to how the patient died, if this is a medical legal case, then of course, it would be the medical legal officers, no, at PNP, or in the US, no, the US, or in Australia, in the Commonwealth nations, you also have your coroners who can do that for you. Pero sa atin, sa Pilipinas, yung medical legal officer, kadalasan sa PNP Crime Lab ang pwede. So these are the individuals who can issue or who can certify the death of an individual. Now, why is it important that we have the certificate of death accomplished? There are several uses. First is the prima facie evidence of death, again for purposes of claims, benefits, insurance, or tax exemption. Evidence of settlement of estate. This is something that we don't normally talk about, but as doctors, we should tell our patients, I'm sorry, we should tell our patients of the importance of estate planning. Um, Earlier this afternoon, we had a talk on hospice and palliative medicine at the URM Memorial Hospital. And one of the in hospice and palliative medicine is one of the subspecialty clinical fellowship that family and community medicine doctors in the Philippines can pursue. Our during my at the UP Philippine General Hospital when I was a resident, I remember we would have talks on legal issues pertaining to estate planning, no? Bago refer sa hospice, alam mo nang mamamatay yung pasyente mo, lalo na kapag landed, maraming titulo. Ay nako, I'm telling you, mas mahirap ang pag-settle ng mga tax, pag-settle ng yung mga mana, mahirap ngayon ang mana, mas maganda pang ibenta yung lupa, yung pag-transfer ng titulo from a deceased person to his or her heirs. It's a little bit tricky. So it's something that we need to really look into. Remarriage purposes for surviving spouse, designation of a guardian or foster parent for minors, and determining health priorities for prevention of death due to similar causes in the future. So these are just some of the many possible uses of the certificate of death. But of course, the information is also significant for family members so that they know what caused the death and are aware of the conditions that may occur or could be prevented in other family members. Especially for us family and community medicine practitioners, we really give so much premium on how do we engage the family, especially during if you're talking of chronically ill, terminally ill individuals, preparing a good quality of death is something that the family members will also truly appreciate. And that is why, as licensed doctors, so we also cater to the psychosocial needs of the family members. And the death certificate can also serve as a reminder for the family members of the struggles that they've had when dealing with coping with the death of a loved ones. Of course, uses of the death statistics, it would provide indicators of existing infectious diseases or epidemics that would need immediate control measures when we're talking of public safety in the context of disease prevention and eradication. For administrative purposes, no, gaya na sabi ko, when we're talking of the five-star physician, we always emphasize of being a manager. Let's say, for example, naging DOH secretary ka or undersecretary ka, how much will you allocate funds, no, of the budget? Siyempre, we don't want confidential funds that have no transparency. So when you are coming up with a budget, you want to make sure that your budget would focus on what is really needed. So yung mga ganitong mga issues, no, bakit we prioritize on one condition over the other, it's part and parcel of that, no? Or if you've heard of the Z benefit package of the PhilHealth, no? Nag-expand na yun. Dati we're only talking of cancer. Now we included in the Z benefit package kidney transplantation, hemodialysis. Bakit? Kasi that's part of the complications of diabetes. Remember, diabetes is the fifth highest mortality condition in the Philippines, cause of mortality among Filipinos. And so we need to allocate funds for that. So you see, this is the reason why we need to look into data. Hindi lang siya purely medical, but from a psychosocial, socioeconomic perspective, it is imperative that we are also aware on how to use the death certificates. For the control of infectious diseases, public safety, accident prevention, and crime eradication, mortality surveillance, health and epidemiologic research, health policy program planning, study of mortality differentials, among other things. This is something that is also very important now when we're talking again, going back to Trump's inaugural speech, no? Sabi niya, ang kanilang health system daw will no longer provide for the needs of the transgender people. So importante din yun, no? When we're talking of health policy, program planning, you look into leading causes of morbidity and mortality. Talaga bang malaki ang nawawala sa gobyerno? Parang importante maintindihan yun. Bakit we need, it is, it is very crucial that even as young freshman medical students, you know why it's important that you are aware of the importance of health statistics because that can dictate even the way society responds to a medical condition or a medical phenomenon. So this is the certificate of death. As I mentioned earlier on, this is the challenge because you need to come up with the causes of death. No, again, you have your immediate, your antecedent, your underlying cause, and there are certain other medical conditions which can contribute, whether directly or indirectly, to the demise of a patient. So the most recent condition written on the topmost line of the certificate is the one that leads directly to the death of the person. Other intervening causes of death would occur in between the underlying and the immediate cause, and these are called your antecedent cause. And the underlying cause is the disease or injury which initiated the chain of morbid events leading to the demise or to the circumstances of the accident or violence which produced the fatal injury. For purposes of public health information and health statistics, usually we look into the underlying cause for mortality purposes. Now, part two of the medical certificate would also look into other significant or contributory coexisting or pre-existing diseases or conditions. Now, notice that there is also a dedicated portion in the certificate of death that would look to interval between onset of death and the death itself. It's imperative that we also give a timeline as to when these causes happened, no? Um, and the assumption is whatever is the underlying cause, it would have the longest duration, followed by the antecedent cause, and the immediate cause is something that would have the shortest duration. So if you are coming up with your death certificate, then you have to ensure that there is also a chronology of events in the interval wherein the longest duration would be the underlying and the shortest duration would be the immediate cause. I remember when we were resident doctors before in at the Philippine General Hospital, and we would rotate. So the family medicine residents would rotate in the internal medicine wards for 2 months, and we were regarded as internal medicine residents who should have the competencies of an internist during our 2-month rotation and internal medicine. Hindi kami saling kat-kat lang doon sa rotation. And I remember when we were tasked to accomplish a certificate of death, sometimes our consultants would sit down and really discuss the causes of death, and we would even argue as to what will be the immediate, antecedent, and underlying causes. And they were very particular as to the duration or the interval between from one cause to the next, because it's something that is very academic, yet at the same time, it is important from a public health perspective. So as I've said, this is what I've mentioned earlier on. There should be a correct sequence, and you should know what happened first and which would have the longest time interval. Now, for the infant death, so if you look at the certificate of death, if you have an infant, meaning to say, uh, 0 to 7 days of age, they would also ask us. So we also rotate in pediatrics. We have a 2-month rotation. The FM residents will often rotate in the Department of Pediatrics for another 2 months. And sometimes you will also be tasked to accomplish the certificate of death for infants. So here it's a bit different because in the cause of death of your infants, they also have the main condition, other diseases. But here, the health of the mother also influences the health condition of the child. So, for example, there are children who are born, especially the premature babies, they can be born with what we call your hyaline membrane disease, meaning to say the lung or the pulmonary functions of a neonate is not yet fully, the pulmonary system of the neonate is not yet fully developed, primarily because of immaturity, the lack of surfactant. Surfactant is a protein needed for the normal gaseous exchange in the lungs. Perhaps, I'm not sure where you are. Are you done with um pulmonology in physiology first year? Tapos na ba kayo? Have you talked about pulmonology in physiology, freshman? Hello?
Hello po, sir. We talked about the respiratory physiology po.
So have you heard of hyaline membrane disease?
Hindi po, but we know the importance of surfactant po.
Okay, so yeah, so you know the importance of surfactant. So let's say patients um who are born premature, they lack surfactant, and so they can suffer from hyaline membrane disease. But why was the baby born premature? Sometimes it's because a mother may have, let's say, a condition which is your preeclampsia. Preeclampsia basically presents with proteinuria, elevated blood pressure, and sometimes this can cause early fetal distress, and it can cause early prematurity to develop. And where do we normally see preeclampsia? It's common among children who become pregnant, the high risk teenage pregnancy. So if you are to fill up this certificate of death for an infant, you're not just focusing on what led to the demise of the baby from a biological perspective, but you also focus into the maternal health, because these conditions can also precipitate the early demise of an infant. And so it's important that we are also familiar with this one. Now, we also want you to become very competent in accomplishing the certificate of death, and we want you to avoid use of what we refer to as your ill-defined and your non-specific causes of death. When we're talking of ill-defined causes of death, under ICD-11, they are considered vague categories, and they would include conditions that would look into signs and symptoms and abnormal clinical and laboratory findings. However, they do not provide sufficient detail for us to come up with a medical diagnosis that will be of clinical or public health relevance. Hence, as a rule, ill-defined conditions should never be entered as an underlying cause of death on the certificate of death unless nothing else is known about the disease. Another common error or mistake is that there are doctors who would report specific organ failure or the mode of dying as the underlying cause of death, rather than a medical condition that triggered the cascade of events leading to the demise of the patient. These conditions are also considered ill defined and ergo should not be reported as the underlying cause of death since they do not usually occur without a precipitating cause. Therefore, if an organ failure is reported on the certificate of death, the underlying condition that triggered that failure should likewise be reported. So these are some examples of your modes of dying that should not be reported. For example, heart failure, uremia, syncope, or shock. When you say shock, there's usually multiple organ failure because of poor blood perfusion. When we're talking of kidney failure, why did the kidneys fail? Is it because of diabetic nephropathy? Is it because of congenital polycystic kidneys? Is it because of hypertensive nephrosclerosis? So you have to identify what triggered the kidney failure. When we're talking of, let's say, heart failure, is this because of ischemic heart disease? Is this because of thyrotoxic heart disease? Is it because of congenital valvular heart disease? You need to give the etiology that precipitated or that led to the mode of dying of an individual. So there are also what we refer to as your garbage codes. So again, these have this is the old ICD-10. As I've mentioned earlier on in my previous slide, I said ICD-11. So there are now what we refer to as ICD-10 codes, which are considered garbage codes. They are non-specific, so we do not want them in the death certificate. So we do not want myocarditis, which is unspecified. Is the myocarditis secondary to dilated cardiomyopathy? Is this a viral infection, perhaps secondary to a Coxsackie virus? When we're talking of cardiac arrest, bakit nag-cardiac arrest? Meron bang because of fatal arrhythmia? We don't know. Or is there electrolyte imbalance? You have to be very specific. And we don't want to use such garbage codes in the death certificate. We're also trying to shy away from the mechanistic terminal events. These are basic pathophysiologic or biochemical derangements that are common final pathways that explain how a cause of death exerts their potential lethal effects. However, they are not very useful in terms of medical diagnosis and for us to come up with the actual cause of death. And so we want to shy away likewise from the use of your mechanistic terminal events. Yung mga ganito, cardiopulmonary arrest. Matatawa kayo, no? Minsan sa TV, makinig kayo sa police report. What is the cause of death? Cardiorespiratory arrest. Meron bang taong buhay na nagkaroon ng cardiorespiratory arrest? Siyempre, pag may cardiorespiratory arrest, it already tells us the cessation of breathing, cessation of the heart beating. So, paano ka mabubuhay? It's not compatible with life. That's why it's a mechanistic terminal event or even a systole. Di ba? When you say a systole, literally your heart is no longer relaxing and contracting in the proper way. That's why we do not want cardiopulmonary arrest or any other mechanistic terminal event to be stipulated in the certificate of death. Again, just to reiterate, sepsis, we normally hear of this when you're talking of sepsis. There is a Bible in internal medicine, we call it Harrison's. If you read Harrison's, they have what we call your Sears criteria. Your Sears criteria will talk about the systemic inflammatory response syndrome. And if there is a potential focus of infection, on top of the Sears criteria. When I say Sears criteria, there could be hyper or hypotension, hyper or hypothermia, hyper or hypocapnia, and then there could be leukocytosis or leukopenia, and then if there's a focus of infection, then that would become your sepsis. If you can identify multiple foci of infection, then yun na. Yun yung pwede nagkukos ng sepsis. But you cannot just put sepsis as the cause of death. That's why you need to specify, is this urosepsis? Is this sepsis because of community-acquired pneumonia on top of hospital-acquired pneumonia on top of ventilator-assisted acquired pneumonia? VAP, a cap on top of HAP on top of VAP. So there are lots of conditions that you need to explain as to why there are ill-defined complications. And again, if you want to use such ill-defined complications, you need to categorically specify the underlying cause as well in the certificate of death. Now, another important fact here is we give also importance to death of women of childbearing age. I'm not sure if it was mentioned by Dr. Dukeli in her lecture last week, but this is a favorite board question. What is the overall indicator that would talk of the overall health of a population or of a community? It's your infant mortality rate because your infants are expected to reach adulthood. So if infants die before the age of 1, it tells you that there is poor quality of health in a locality. On the other hand, if you are asked among the health indices, what is the most sensitive to the quality of available health services? It's your maternal mortality rate. Why is that? Because pregnancy is a physiologic phenomenon. You shouldn't see women die because of pregnancy related complications. That is not the normal chronology of events. If you go to countries with very good health services, let's say, for example, if you go to Scandinavian countries, they have very low, almost zero maternal mortality rate, which is a reflection of the good availability of health services in their locality. That's why we give so much emphasis on women of childbearing age. If you are dealing with death of a woman aged 15 to 49 years of age, regardless if he or she is pregnant, then there is a part in the death certificate that would look into the maternal death review. So a maternal death would refer to death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration, the site of pregnancy, for example, ectopic, from any cause related to or aggravated by the pregnancy or its management, but not from the accidental or incidental causes. In the Philippines, no, sadly, the top causes of maternal death are as follows: postpartum bleeding, complications from unsafe abortion, hypertensive disorders of pregnancies, which would include your preeclampsia and your eclampsia, postpartum infections, and obstructed labor. Another sad reality in the Philippines is that abortion is considered illegal in the Philippines. Abortion in all its forms is illegal in the Philippines. I remember when I was a resident, the first time I delivered an anencephalic baby, it was very difficult now because the mother knew her baby was anencephalic, meaning to say there was failure of the anterior neuroport to properly close, and so the brain of the baby is open. It did not close. The skull did not close. And anencephaly is incompatible with life. But a woman, despite knowing that she has an encephalic baby in the Philippines, is forced to complete the pregnancy, deliver the baby, and literally wait for the baby to die because anencephaly is not compatible with life. because abortion is not legal in the Philippines. The World Health Organization supports therapeutic abortion for certain conditions. One of which is that if you have children who have congenital defects, you may opt for abortion. But in the Philippines, what happens is that because it's illegal, women would resort to non professional methods of abortion or unsafe methods of abortion. And so when you receive these women in the hospital, they've already undergone septic shock. Because sometimes when you even insert a speculum in the vaginal orifice, you would see several cytotec or methylsoprenol inserted in the vagina to induce the it's because it's an abortifacient to induce the abortion process, and this can lead to septic shock that can lead to the death of a woman because of unsafe abortive practices. So just the sad reality, no, that we see among Filipino women. Now, in the same manner, there are certain times wherein you are not sure of the definitive diagnosis. So we are allowed to use certain terminologies like presumed or probable. For example, if you are not yet sure if a patient really has Cox infection, in the clinical practice guidelines, we refer to these individuals as having presumptive pulmonary tuberculosis. So putting the terms probable, to consider, presumed, or presumptive, these are okay. Or sometimes, if there's really no, it's an enigma. We don't know what caused the death of the patient. Sometimes it can be placed undetermined natural cause. And this is something that is considered acceptable. So again, just to highlight other important things. So if you have a certificate of death, always put an X mark. Please make sure you properly spell the name correctly. We do not allow alterations or erasures in the certificate of death because this is a legal document. We do not use abbreviations or medical symbols, and we only allow the use of black ink. So whenever you come up with this with a death, only one etiology or one cause per line of death. The immediate cause must always have an entry, but sometimes the antecedent can be blank, and then there could you can also put something in the underlying cause. Now, there are also deaths that could be secondary to external injuries. So, trauma, so these are, let's say, motor vehicular accident, drowning, electrocution, ano pa ba? Or yung mga, sadly, no, yung mga those who were able to, um, those who died of suicide. So these are considered external causes. So here, when we're talking of external injuries, we also have to identify immediate, antecedent, and underlying cause. So for the immediate, we can put fatal derangement. For example, if there is note of hypovolemia, meaning to say there could be massive blood loss, because of the amount of blood loss, it led to hypovolemia. And why was there hypovolemia? There could be multiple fractures or sadly blunt force trauma from an external event such as a motor vehicular accident. Now, notice that under 19D, if this is something that is external in origin, we have to identify if this is what is the manner of death? Is it homicide, accident? Where did the is this occupationally related? And is autopsy warranted? It's imperative that you also identify all medical legal cases. In theory, all all medical legal cases should undergo autopsy before burial. Well, there are a lot of limitations um, with autopsy. First, there are very few pathologists who can really perform the autopsy. Second, not all family members will agree to autopsy, although technically under Philippine laws, If it is medical legal, then there should be an autopsy prior to the burial or the cremation of the body or the corpse of the patient. So there are a lot of issues with that. If it is something that is infectious in origin, that is of public health importance, now you also have to identify certain conditions. For example, if this is pneumonia, let's say, for example, among the persons living with HIV, is this Girovechi, pneumocystis Girovechi pneumonia, or let's say, for example, if this is meningococcemia, no, so meningitis from your Neisseria meningitis, so you need to report these, especially if you know the etiology, then, or sometimes we just put cause unknown, the source and route of infection, and the underlying cause. In the manual and review notes, there is a supplemental reading that they expect you to fully comprehend and understand, because I will definitely lift questions coming from the manual from for the upcoming exams. So make sure you read on these, because there are supplemental information that you can derive from the review notes and manual. If you're dying from malignancy or cancer, we also have to identify primary sites, meaning to say there are types of cancers that are known to be capable of metastasis to other organ systems. And sometimes you can have uh, a secondary growth. So you have to identify if the death is secondary to cancer, what particular neoplasm occurred first. Although there are what we call your double primaries, wherein two types of cancers develop independent of each other, which is also possible. It's like having a double whammy, but it's something that you might encounter in the clinics. It is also important that you know, because the primary site is the one that is normally reported as the underlying cause for purposes of statistics. For example, when we're talking of breast cancer will have a chance to metastasize to the lungs, to the brain, to the lymph nodes, um, or let's say if we're talking of your gestational trophoblastic disease, which is a type of gynecologic malignancy, also can go to the lungs or to the brain. So you have to identify the primary site, and this will be reported as the underlying cause. And the underlying cause will be the one that would be noted in the statistics. I'm not sure if during your TikTok videos last semester, if any one of you talked about cancer. In the Philippines, there are different statistics when it comes to leading causes of cancer among males, among females, and among the pediatric population. Now, fetal death refers to the demise prior to the complete expulsion of a product of conception, irrespective of the period of pregnancy. The death is indicated by the fact that after such separation, the fetus does not breathe nor show any other evidence of life, such as the beating of the heart, pulsation of the umbilical cord, or definitive movement of voluntary muscles. Now, it is important that you need to talk about the difference between a fetus and an abortus for all fetal deaths above 20 weeks of age. So the cutoff that will differentiate your fetus from abortus is the fact that a fetus is 20 weeks or above, while an abortus is 20 below 20 weeks. Or sometimes it can also be based on the weight of the product of conception. Normally, the fetus is dated from the last menstrual period of the mother. When we say last menstrual period, it is often the first day of the last menstrual cycle, not the last day of the last menstrual cycle. It's the first day. So why is it important that we know of the fetal death in utero? So when we're talking of fetal death in utero, kasi pwedeng yung fetus, it could have, the fetus could have died before labor, during labor, or if you don't know. There is also a condition which we call your abruptio placenta. Again, pardon for the examples. Again, this would require knowledge of obstetrics and gynecology. But abruption placenta can happen when there is premature separation of the placenta. And we do know that the placenta will serve like a bridge connecting the mother and the fetus. So if there is abrupt separation of the placenta because of preterm labor, that would lead to the early expulsion of the baby and or the death of the baby. And this is commonly seen, for example, for women who are sadly substance users. No? In particular, cocaine intoxication can result in preterm labor that can trigger your abruptio placenta. So it's also noteworthy that you also have to know to be familiar with the terms early term baby, full term baby, late term baby, or post term baby. Again, as I've said earlier on my disclaimer, I am interjecting basic knowledge in pediatrics, but you're only a freshman medical student, so you might not be aware of these medical terms. So for academic purposes, I'm also sharing these with you because it's also imperative that you should be able to quantify the length of pregnancy of the baby for you to report the fetal death. So again, this is something that we've already mentioned earlier on how to accomplish the fetal death. But there is also what we call your peri-procedural death. There is a misperception when we're talking of peri-procedural death that it's often because of malpractice or negligence of the doctor, which is not exactly true. Peri-procedural death refers to the demise that is known or suspected as having resulted in whole or in part from diagnostic, therapeutic, anesthetic, or operative procedures. That is why whenever you go if you undergo any invasive procedure, we always do the informed consent and you are required to sign legally the informed consent because there are risks for all of these diagnostic, therapeutic procedures and to free the doctor from any liability that may arise from any potential peri-procedural death, then it is important that you are aware on how to deliver or how to secure the informed consent. It is also sometimes referred to as misadventure or iatrogenic or errors or accidents in medical nature. However, these have a negative connotation when in reality, sometimes patients and their relatives are fully aware that there are risks associated with the procedure, but still they are willing to undergo the procedure for its potential benefit rather than fearing the potential harm. Again, although such words may connote negligence, please take note that many procedural deaths do not actually involve negligence, mistake, or culpability. So there are periprocedural deaths which are natural, and there are those which are accidental. Periprocedural death that is regarded natural would refer to death that was imminent and that it would have occurred anyway, even if the procedure was not done. In contrast, accidental periprocedural death occurred, um, but you are quite confident it would not have occurred if the procedure was not carried out or was not facilitated. So again, emphasizing the need for looking into medical legal conditions, no? We need to report. We are mandated by law to report if you are suspecting any death secondary to a medical legal condition. We are to report promptly to the authorities, either the PNP or to the National Bureau of Investigation. So, who are these individuals? Those who are victims of stab wounds, gunshot wounds, suicide, strangulation, accidents, physical assault, or other acts of violence upon a person that can lead to death and sudden death of undetermined cause. Yung mga sudden infant death syndrome, di ba? Yung mga parang, or yung mga bangungot, yan, kung minsan it could be considered if you don't know the etiology, then that could be considered medical legal in nature. Now, here is another controversial issue that you need to understand. dead on arrival. When a patient comes to the emergency room, hindi porke dead on arrival, literally wala ng pulso, walang heartbeat, nothing. There are those patients, when you receive them at the emergency room, you can still revive them, you can provide initial resuscitative measures, but eventually they expire. Now, in its strictest sense, there is no hard and fast rule on this. But the usual practice is if a patient enters the hospital facility at the emergency room and dies within 24 hours, not necessarily on the spot, namatay within 24 hours, you can label that person dead on arrival. Let me be quick in saying that that is an accepted practice. However, it is not written in any document. So if a person, if you are the ER doctor, you saw the patient, let's say, with no vital signs, or let's say 30 palpatory, and then you were able to revive the patient, and then the patient's blood pressure rose to about 90 over 60. But after 20, but within 20, before the 24-hour, the patient crashes once again and dies. Kahit na you were able to perform and perform tests, administer drugs, basta less than 24 hours, the usual practice is you can call it dead on arrival. Why is this important? If this is the case, the assumption is the attending doctor did not have ample time or sufficient encounter for you to come up with a definitive diagnosis for the patient. And therefore, you can ask the medical legal or the health officer, the city health officer, to be the person to issue the certificate of death. So yun yung tama. Pwede mong i-demand na I did not have ample time to fully assess the patient and the patient died within 24 hours under my care, then therefore it is considered dead on arrival. However, let me be quick in saying, especially for those in the smaller hospitals, sometimes out of humanitarian reasons, they still accomplish the death certificate kasi naawa dun sa pamilya or kasi kung minsan, no, pag minalas ka, let's say, meron kang dead on arrival ng Monday, Thursday. Ang mga opisina, ang City Health Office magbubukas pa ng the next Monday. So Monday, Thursday, Black Friday, Good Friday, Black Saturday, Easter Sunday, 4 days, sarado yung City Health Office, wala mag-i-issue ng death certificate. Monday pa. Baka Tuesday pa lumabas yung death certificate. So kung minsan may mga ganon, yung mga doktor sa ER, sometimes they're very compassionate. They do the death certificate on their own. But in reality, you can opt not to accomplish the death certificate because technically that is dead on arrival. Another important, now we go to the certificate of live birth. This is also one of the civil registries that we need to accomplish. Here, ang importante is you should be knowledgeable on how to identify the OB code of a woman. When we're talking of the OB code, every woman, um, okay, let me qualify that. Every biological woman would have the gravidity and the parity. When I talk of gravidity, it denotes the number of pregnancies, whether present or past, regardless how long the pregnancy lasted. On the other hand, parity refers to the state of pregnancy until the period of viability. Ibig sabihin, nanganak. Both gravidity and parity refer to pregnancy and they do not count the number of babies. So, for example, if you have a woman who becomes pregnant for the very first time and she delivers twins, she is regarded gravidity 1, parity 1. Hindi siya nanganak na, hindi siya nagbuntis ng dalawang beses, hindi siya nanganak ng dalawang beses. Nanganak minsan lang nagbuntis, minsan lang nanganak. So it's important that you know the difference between gravidity and parity. Now, here is where a little bit of controversy would come in. As doctors, you should be knowledgeable on issues on paternity. If you are dealing with common law spouses, meaning to say, magka-live-in lang, ano bang sinasabi ng batas natin pagdating sa magka-live-in? Or those who are common law spouses? Under the family code of the Philippines, again, that's why I said I'll be touching on a little bit of legal med, but you will have legal med in third year during your medical jurisprudence and legal medicine courses. At the back of the certificate of live birth, you have the affidavit of acknowledgement or admission of paternity. This is for those couples wherein there is no legal marriage, walang civil registry for marriage, and these are children who are considered illegitimate. So if you are dealing with an illegitimate child, under the new family code, if the mother acknowledges the biological father and the biological father is willing to sign the back portion of the certificate of live birth, then under Philippine laws, this is acceptable. We have to differentiate a legitimate child versus an illegitimate child versus your legitimated children. Who are your legitimate children? Any child born out of the usual legal marriage, they are considered legitimate. Oh, sorry. Now, there are times that you have to deal with children who are born illegitimate. Um, After the family code, the new family code, no, dating after August 3, 1988, illegitimate children, meron kasing issues with the way an illegitimate child, whether or not he or she can use the surname of the father. So if you look at the provision, an illegitimate child has the right to bear the surname of the parent recognizing him or her. However, an illegitimate child who is not recognized or acknowledged by both parents in accordance with the law shall be registered under the surname of the mother. So kapag kayo ay nasa ospital and then you are asked to accomplish the certificate of live birth and you are dealing with live-in partners, common law husband and wife, then there should be admission of paternity and the affidavit to use, affidavit of acknowledgement that will be placed, that will be signed at the back of the certificate of live birth. Sometimes it's possible that the affidavit to use the surname of the father would come after the certificate of live birth has been already registered. Kasi there are instances wherein, for example, mag-boyfriend, girlfriend, pero yung lalaki OFW, tapos yung nabuntis na babae, naiwan sa Pilipinas ng anak. So nung nanganak yung bata, yung pinanganak yung bata, the biological father is not physically around. So there could be a subsequent affidavit to use surname of the father, but this will also undergo a legal process. And once the family court approves the affidavit to use the surname of the father, there will be a stamp on the certificate of live birth and and an attachment of the affidavit that was being approved by the court for the child to use the surname of the father. This is very important because in terms of succession, iba kasi ang inheritance ng legitimate versus illegitimate children. But you'll learn of that when you go to legal medicine and medical jurisprudence in third year. Now, similarly, the father of an illegitimate child who wishes to have his name indicated in item 13 of the certificate of life shall execute an affidavit of admission of paternity in lieu of the affidavit of acknowledgement. Now, the purpose of admission of paternity is for the support and succession only and does not entitle the illegitimate to use the surname of his father automatically. Kaya importante na whenever we're talking of illegitimate children, you should be able to talk to a lawyer that will discuss this. Now, what about now an illegitimate child shall use the surname of his mother, regardless of whether or not his father admits paternity. So nasa batas kasi natin yan. Now, there is a difference now between a legitimated child and an illegitimate child. Let's say, for example, a child is born out of wedlock, but at the time of his or her conception, both parents have the legal capacity to be legally married, and then nanganak, then after the marriage, the couple marries legally, the illegitimate child becomes legitimated. Meaning to say, the legitimated child will have the equal rights as that of a legitimate child. But for example, the biological father is married to someone, and then the mother is a single mom, kabit, nabuntis. Dahil yung lalaki, nung time na siya ay nanganak, by the time the child was delivered, the man did not have the legal capacity to marry the woman, then that child will forever be illegitimate unless this person gets an annulment and then they get married, and then this biological father will legally adopt the illegitimate child. So medyo complicated, no? But again, I'm just citing because you need to understand from the context of family medicine, we are sometimes dealing with such drama in the clinics or in the hospital. So you also need to be aware of these conditions. Then again, the fetal death in utero, I've said this earlier on, any birth that is any product of conception less than 20 weeks is considered an abortus. Above 20 weeks, it's a fetus. Or if that is considered if the product of conception is less than 500 grams, then that is considered an abortus. So again, we go back to the OBGYN code. It's important that you are aware that after the gravidity and parity for women, we also identify if the previous pregnancies will be full term, preterm, if there has been previous abortion, and the current living children. So for example, um, I am a woman and I've been pregnant 3 times, but I only delivered uh twice because the last child I had an abortion, spontaneous abortion. So G3, that's G3 because 1, 2, 3 pregnancy, but P2 because I only gave birth twice. Now my firstborn was born full term, but I delivered to 2 preterm twins. So if I am that woman, my OB code would be G3P2 1 1. F is full term, preterm is 1, abortion is 1, then I have 3 living children. Kasi firstborn, then the twins. So I would be G3P2 1 1 1 3. That would be my OB code. Again, that stands for FPAL. FPAL would count the number of full-term babies. P would count the preterm babies. A would be abortus. L will be the living children. So it's important that you understand na kapag sinabing full term, it's 37 weeks and above. Anything less than 37 weeks, we call them preterm. So again, just to reiterate, if I'm a first-time pregnant woman, and I delivered two live twins who are both full that I delivered full term, then my OB code would be G1P11002. So this afternoon, what have we discussed? In summary, I know it's a bit of information deluge because, as I've said, it entails knowledge of internal medicine, pediatrics, obstetric gynecology, and a little bit of legal medicine, third year subjects in our institution. And you're still freshman, but I hope I was able to properly summarize everything for you. So various sources of morbidity and mortality data. When I say data, I can refer to primary or secondary data that can be used in public health studies and epidemiologic investigations. Some pertinent public documents are related to civil registries of vital events. This would include the certificate of death, certificate of fetal death, certificate of live birth, and it's important that we also identify community health indices, which are public health significance. And this could include your cause specific incidence and prevalence rates. And it's important that you're able to properly assimilate data, even let's say from other sources, because that will be essential when you are to come up with, let's say, public health interventions, policies, or even preventive measures and control measures. For this afternoon's lecture, I used the following references. So before I continue, do I have questions or clarifications from the students? Kindly raise your hand and I will acknowledge you. Yes, Miss Al Ismail. I hope I said your name correctly.
Sir. Hello po, sir. I just wanted to ask about the underlying cause, like especially if the patient or the person who passed um has multiple chronic conditions like hypertension, diabetes type 2. Do we report the one that contributed to the antecedent and in turn contributed to the immediate cause?
You need to look into the way the medical conditions are interrelated.
Mhm.
Normally, when we're talking of the underlying causes, all of these can be contributory, but normally you should be able to see the direct link of the immediate, then the antecedent, and the underlying cause. And then for other medical conditions, that is what you can put under um other contributing conditions. However, it's different when you're talking of the ill-defined causes. For example, when we're talking of heart failure, is this heart failure because of, let's say, the tetralogy of Fallot, or let's say, is it because of thyrotoxic heart disease, because there's already uncontrolled Graves' disease. So I know it's a bit challenging for first year medical students, but basically, when you go to higher medicine, you will see like a pattern of how medical conditions are interrelated, and how each of these would lead to the cascade of events leading to eventually the demise of the patient. Did I answer you?
Yes, po, sir, because there was one case in the exercise where the person had hypertension and diabetes, but her death was caused by a diabetic coma. And I was just wondering if I should put the underlying cause as diabetes type 2 and then hypertension as another condition contributing to that.
Okay, so for example, if that is the case, when we're talking of your diabetic ketoacidosis, so there are two types of diabetic coma. It could be your hyperosmolar non-ketotic state or your diabetic ketoacidosis. More often than not, your diabetes and your hypertension, they are both part of the metabolic syndrome, together with obesity and together with dyslipidemia and other hypercoagulable states. But if you look at the actual events leading to the death of this patient. Sorry, I wasn't able to read the manual exercise, but if you read that, if you are saying that there is a history of diabetic coma, then what would be the underlying cause? Would be your diabetes mellitus. I'm assuming there's uncontrolled hyperglycemia. that precipitated the diabetic ketoacidosis and or diabetic coma of this particular patient. Sorry, I wasn't able to read the manual exercise.
Thank you, sir. I also have another question. I don't know if this was intentional in the manual po, because in some cases, the reader's role was specified, like, oh, you're the clerk or you're the physician. But I think there were like two cases where the role was not specified, and I was wondering, like, what do we put as our role there?
Um, well, if the task at hand is you are to accomplish the death certificate, if I remember the if I understand your question correctly, then the assumption is you are a licensed doctor, but as clinical clerks, you may be required to assist the attending doctors, the residents in coming up with the diagnosis. So if it's not stated, the assumption and the task at hand is to write a certificate of to accomplish a certificate of death, then most probably the role will be that of of a doctor. Did I answer you?
Yes, po, sir. Thank you.
Are there any other questions before we proceed to the last part of the lecture? So I hope I'm not giving an information deluge for everyone. But for the last 9 minutes of the afternoon, so I want this to be a little bit more interactive. So at this point, I'll be requesting the students to please enter something in the chat box. I'll show you, if you're familiar with 4 picks, one word, I will show you several photos, and you are to give me the words that I'm looking for that are related to this afternoon's lecture. The first person who would correctly type in his or her answer in the chat box would be duly recognized in the next couple of weeks. Can I ask Miss Pau to please take note of the name of the first person who would be answering it correctly? So are you guys ready for 4 picks, one word? If yes, can you please give me a heart icon? I'm not seeing any heart icon, only one. Okay, I want to see more heart icons, please.
Hindi po nakikita yung chat to everyone.
Wait lang. Please allow chat for everyone. Okay na raw. Okay, so let's start the first 4 picks, one word. Oops. Kindly typing your answers now. Mahirap ba? Ba't wala nagtatype ng sagot? Guys, type in. No, not. I'm referring to. Okay, so we have the correct answer. It's Miss Genesee de Torres. It's your primary data. Okay, so thank you for that, Miss. Can you please take note of her name, Miss Genesee de Torres? Okay, next 4 picks, one word. So for those of you who are not familiar with these images, okay, so we have one winner. Para walang, so this is correct. That's notifiable diseases. So Miss Via Marie Lionel Kaliwag, thank you for your answer. You're the only one who responded to 4 picks, one word. Sobra bang cerebral? Hirap ba? Okay, next, in the final 4 picks, one word, I will coordinate with Dr. Wangko and Dr. Alcanzari as to what incentive we will be giving to these 3 people who answered in the 4 picks, one word. Last will be this one. Okay, thank you, Miss Denise Ann Caceres. The correct answer is civil registry. So, Ms. Pau, please take note of their names. I will get back to you guys as to what incentive you'll be getting. So, this afternoon, we talked about the different types of data. We've differentiated primary and secondary data. From a public health perspective, it's imperative that we are familiar with what are the sources of data. These data can be part and parcel of public health interventions, health policy development, especially when we're talking of your notifiable diseases. And part of the tasks as doctors is we're also able to identify important life events, the vital life events, and we are required by law to report all of these to the civil registry. So with that, thank you and good afternoon to everyone. If there are no other questions, class is now officially dismissed. Thank you very much for your kind attention.
Thank you, sir.
Thank you, sir.
Thank you po.